Fatal injuries account for 40% of the cost of to construction workers. Non-fatal injuries and illnesses, mainly injuries with lost workdays, account for the rest. On average, the death of a construction worker results in losses of $4 million, and a non-fatal injury with lost workdays that cost approximately $42,000. These estimates include direct costs such as payments for hospitals, physicians, and medicine, indirect costs such as wage losses, household production losses, and cost of administering workers' compensation, and quality of life costs that's attributed to the pain and suffering that victims and their family experience as a result of injury and illness. Employers in construction spend more on workers' compensation than any employers in any other industry. In 2005, of all employer costs in construction, 5% were spent on workers' compensation, more than double the cost of manufacturing employers and almost 3 times the average cost for employers in all industry. Hazardous exposures in construction include air contaminants such as wood dust, abrasive blasting dust, gypsum and alkaline dust, silica, asbestos, lead, diesel exhaust, and welding fumes. The third most dangerous profession is healthcare. More than 14 million people, greater than 10% of the employed in the United States, work in healthcare. About 80% of healthcare workers are women. The healthcare sector includes a greater percentage of African Americans and Asians, but a lower percentage of Hispanics than all other industries combined. Healthcare workers probably confront a greater range of significant workplace hazards than any other workers in any other sector. Biological hazards associated with airborne and bloodborne exposures to infectious agents, as well as chemical hazards, especially those found in hospitals such as waste, anesthesia, and sterilant gases, hazardous drugs and other therapeutic agents, mercury and industrial strength disinfectants and cleaning compounds. There's also physical hazards, including ionizing and non-ionizing radiation. Safety and ergonomic hazards which cause a variety of acute injuries and chronic muscular disorders are common in healthcare, as well as violence, including physical assaults and threats of assault, and psychosocial and organizational factors, including work stress, staffing, and shift work. In 2007, the occupational injury and illness rate per 100 workers among hospital workers was 7.7, and nearly double that of the overall private sector rate at 4.2, and higher than the rates for workers employed in mining at 3.1, manufacturing 5.6, and construction at 5.4. Workers in nursing homes had an even higher rate of occupational injury and illness at 8.8 per 100 full-time workers in 2007. There's a deep-rooted belief that patient health and safety supersede worker health and safety, and that it is acceptable for healthcare workers to have less than optimal protection against workplace hazards. Both patient and worker hazards arise from the same source: healthcare practices, products and materials, and the built environment. The generation and disposal of biological, chemical, and radiological waste also pose a risk to the communities around healthcare facilities and beyond, especially if these facilities incinerate their own waste on site. In 2005, the incidence of occupational illnesses among healthcare workers was 39.9 per 10,000 full-time workers, compared to 26.7 in private industry and 19.6 in the service industry. Non-fatal skin diseases and disorders, 7 cases per 100,000 workers, and respiratory conditions, 5.2 per 10,000 workers, were the most frequently reported illnesses. Healthcare workers specifically suffer the greatest proportion of musculoskeletal disorders than any other profession. MSDs among healthcare workers are second among all work-related injuries. Exposures include those involved with lifting, pulling, sliding, turning, and transferring patients, moving equipment, and standing for long periods of time. Among all categories of workers, hospital and nursing home workers have the highest number of occupational injuries and illnesses involving lost work days due to back injury. In 2007, nursing aides, orderlies, and attendants had an MSD rate of 252 cases per 10,000 workers, a rate more than 7 times the U.S. average for all occupations. They also reported the most MSD cases involving days away from work, with a median of 5 days away from work. Many registered nurses working for at least 1 year have reported neck problems, shoulder problems, and back problems. Almost 80% of nurses experience low back pain during their working lifetime. The risk for MSDs is also greater when nurses work shifts longer than 12 hours and on evenings, nights, and weekends. The nursing home industry spends more than $1 billion annually in workers' compensation premiums. Healthcare leads other sectors in the incidence of non-fatal workplace assaults as well. Of all non-fatal assaults against workers resulting in lost work days in the United States, 32% have occurred in the healthcare sector. And about half of non-fatal assault injuries, the patients are the perpetrators. In 2005, the BLS rate of non-fatal assaults among healthcare workers was 8.8 cases per 10,000 people, almost 4 times higher than in the private sector. Among assault victims, 30% were government employees, even though they comprise only 18% of the U.S. workforce. In each year from 1993 to 1999, 1.7 million incidents of violence occurs in the workplace. Mental health professionals had an annual incidence rate of 68 per 1,000 workers compared to 12 for all other workers. Nurses had an annual incidence rate of 22 per 1,000 workers. Emergency department workers also faced an increased risk of injuries from assaults by patients or their family members. Most prevalent, least reported, and largely preventable serious risk healthcare workers face arises from the continuous use of inherently dangerous conventional needles and sharp devices that lack an engineered injury protection feature. Unsafe needles transmit bloodborne pathogens to healthcare workers employed in a wide variety of occupations. The physical and mental health consequences of transmission of a potentially fatal bloodborne infection has also remained high since then. One of the least concerning non-fatal risks in healthcare is latex allergies. Prevalence of latex allergies among healthcare workers is estimated to be between 5 and 18%, with atopic workers at greater risk. People with latex allergies are also more likely to develop sensitivity to other allergens, especially food. 3 types of reactions can occur in a person using a latex product: irritant, non-allergic dermatitis, allergic dermatitis, and latex allergy. The most common reaction to latex products is irritant contact dermatitis, with a dry, itchy, irritated area on the skin, usually the hands. Healthcare workers are exposed to also a wide range of chemical disinfectants, such as anesthetic gases and hazardous drugs, that are known to cause adverse health effects. They also have inadequate or no testing. The average hospital contains about 300 chemicals, twice the number of the average manufacturing facility. Over the years, several legislative actions have been put in place to address workplace hazards for healthcare workers. In 1958, the American Medical Association and American Hospital Association issued a joint statement in support of worker health programs in hospitals. In 1977, NIOSH published criteria for effective hospital occupational health programs. In 1982, the CDC published the Guidelines for Infection Control in Hospital Personnel, which focused on infections transmitted between healthcare workers and patients, not only healthcare workers' risk of contracting diseases. They also started the CDC guidelines for blood and body fluid precautions, universal precautions, which came in 1987, and standards precautions, which came in 2007. The latter of which combines the major features of the universal precautions and the body substance isolations, which were published to provide guidance to healthcare workers. That's it on this lecture. We are officially done. Let me know if you have any issues with your critical assignment.